All right, here comes everyone. Welcome, welcome, welcome in everyone. Welcome to Care Concierge with CarePatrol, where education is the heart of everything that we do. We educate our clients who are aging adults and their families about the care journey that they are on or about to be on, and the options for care along the way and the cost. And if we end up finding that someone needs and is appropriate to assisted living, we refer them there, and that's how we earn money. All other discussions we have are at no cost to them, and that's part of our education pledge to our clients. We also educate our providers about folks that may be appropriate for them, and we educate our referral sources, folks like you, about what we've done on your behalf. Hello, everybody. Thank you for saying hello. We're so fortunate today that we have one of our own, nurse CW Merritt, who will be providing our content today for Care Concierge with CarePatrol. And as those of you may know who have been with us this month, our focus has been on clinical issues as delivered by clinicians. And this was, again, the topic that won the poll that I had submitted, I guess, in September. And just so that you know, we tend to try and do topics that you suggest as attendees. You'll be asked in our evaluation if you have any topics that you'd like to see us address, and we'll do our best to do that. But today we're going to receive a clinical talk from a nurse on fall issues and fall prevention. And I'm excited about that. On Friday of this week, we'll have Dr. Duxbury from UAB's School of Gerontology, or Geriatric Medicine, rather. And he will be presenting Medicare 101. There's a link up high in the chat room. If you'll scroll up to the top, you can get to that link to join us Friday as Dr. Duxbury discusses Medicare. If you've not heard him talk about Medicare, you've missed out. It's really a wonderful show and presentation, and he's a terrific speaker, as is our own CW Merritt. And as we're getting more people in now, I'm going to turn our attention to our housekeeping, which is this. We are, as those of you who've been with us know, and those of you who haven't been with us before, we are accredited by the Alabama Board of Social Work Examiners and the Alabama Board of Nursing Practitioners. And each of those boards, the credentials, and allows us to create content and then offer it to you and submit it for contact hours. So we're very pleased about that. And one of the ways that we work with each of those boards to provide these Zoom CEUs as live or face-to-face CEUs and not recorded CEUs is that we have a password protection system. And that is that about 12:50 today will give you the password to the evaluation, which will enable you to open it. And those boards believe that because you were there for at least 50 minutes of the presentation, that it was the same as a live presentation. So these are live, and if you're from another state, they're reciprocal to other states. You have the ability to unmute your mic, and I hope you will join in discussion with CW. I'm sure many of you have experiences that would be, of value to all of us to hear around falls, fall prevention, and fall risk. The nurses and social workers who complete our survey today will receive a certificate. Nursing hours we will post to the ABNP website, which is where your hours are kept and logged. I'm going to read, because some of our folks who join us, I know, are joining by phone or otherwise not able to see a screen. So I always like to read for their benefit our evaluation link. I'll read it twice So if you are not able to see a screen right now, please listen out. I'm going to read our evaluation link. It is at https://www.surveymonkey.com/r/ all uppercase letters, M as in Mary, R, S, B as in boy, Y, W, M as in Mary. And I'll read it one more time. Remember, it is password protected. You cannot access it until we give the password later today. The link is https://www.surveymonkey.com. Thank you, Ashley, who's posted it. surveymonkey.com/lowercase r/ all uppercase letters, M as in Mary, R, S as in Sam, B as in boy, Y, W, M as in Mary. Thank you, Ashley, for posting that. You're always so kind to do that. We've explained who we are and what we do and how much we value you being here. And without further ado, I'll turn us over to our Chief Clinical Officer for CarePatrol of Birmingham, Huntsville, and Montgomery, and my colleague and friend, CW Merritt.
Thank you very much, Sean. And thank you guys for joining us today. Just so you'll know, this is my first ever Zoom presentation. So I'm not nervous, I'm merely terrified, but we'll get through it together. So I'm glad you guys joined. For the purposes of our conversation today in regard to fall risks and what we can do about it, I want to focus a little bit more on community and what we see every day and what we do at CarePatrol. And you see it at the hospital also, I'm sure, and in other environments. So before I even kick off and start, giving the lecture, I'm just wondering, is there anybody on this call who has not had a loved one that was affected by falls? Or how many of you have not had a patient that was affected by a fall? In the audience today, is there anybody who has not experienced that? Yeah, that's what I thought. It's kind of like crickets, because if you've been in this business for long, you've dealt with falls and fall related issues. And if you have loved ones who are aging, you probably, if you haven't dealt with it yet, you may. So today we're going to talk about some risk factors that are not amenable to modification. I want to talk about some risk factors that are amenable to modification. And I want to talk a little bit about how to induce environmental fall risks. Next slide, please, Sean. So if you had to take a guess, how often would you guess that someone falls and has an injury as a result of it in the United States? How often? You're welcome to chime in or unmute your mic, however you want to go about that. Next slide, Sean. So approximately 41 fall-related deaths per 100,000 people per year in the United States. That's pretty eye-catching. There are some pretty reliable statistics out there that say that fully 1/4 to 1/3 of all of our population over the age of 65 will experience a fall in the next year. 2/3 of those falls will happen in the home. And that's kind of where the rubber hits the road most of the time and what we're doing with those patients when we're treating them. Thought another interesting fact to sort of internalize when we're talking about the elderly and falls is that falls are the leading cause of accidental death amongst folks who are over 65 years of age. And then as an interesting note, ladies fall a little more often, but when the guys fall, they do it right, because more men die from their fall than do females. Next slide, Sean. So what this slide demonstrates is if fall risks are on the rise, they're not getting any better. On average, we've got a larger elderly population. People are more mobile. They're trying to stay in their house longer for economic reasons. So as a result of that, we're seeing more and more falls rather than less. And that's pretty much across the world if you look at the statistics from the WHO. Next slide, please, Sean. So, we all know what the negative effects are of folks falling from seeing it in person, but, the financial impact is astounding. The suffering of people who experience falls and the families that go through it with them is really harsh. If you've been there, and I've read some statistics in the past that said that falls are the #1 leading cause, ultimately, in some shape, form, or fashion, for long-term admission to a nursing home. We work a lot in the assisted living facility environment where, a lot of those risks are controlled for the resident coming in. Falls still occur, but a lot of care has been taken to reduce fall risk within those facilities. And I would say anecdotally, probably 9 out of 10 patients and families that I talk to in that environment will relate to me a story of having had a fall. And I'm surprised how many of them have had a broken hip or a broken arm or something to that effect from the fall. Next slide, please, Sean. So this slide just illustrates how the fall rate is increasing in the United States. By the year 2030, we're estimated to have 7 death falls every hour. The math on that is staggering when you look at the total senior population. Next slide, please. So let's talk about some fall risks, some of which we can control, many we cannot. So if you're 65 or older, well, your risk goes up. This particular statistic says 1 out of 4 individuals over the age of 65 will fall each year, but less than half of that tell their doctor. So that in itself to me is a fall risk because people are afraid. Fear of falling is a serious problem. We'll talk about it a little bit more down the line, but people are afraid not only of the fall, but of the outcome. If you talk to folks that are aging and you ask them, kind of what are you worried about? They're worried about losing their independence. And they'll do anything to keep it and anything they can to stay in that home as long as they can. Within that, going back to that prior statistic, if they're staying at home and hunkering in to try to keep from falling, their activity is decreasing, they're probably a little more isolated, and those things in and of themselves lend to an increased fall risk. How about the next slide, Sean? Falls are one of the major causes of mortality and morbidity in older adults. 30 to 40% of patients over 65 will fall at least once. I think that statistic may be low, actually. Falls can cause anything from minor injury or just scaring someone to death. The statistics on a hip fracture over the course of a year are pretty damning in terms of the mortality associated with it. So for many of our patients over the age of 70, a fall with a hip fracture could be a slow death sentence. It's not a kind problem. How about the next slide, please, Sean? So one of the things I wanted to just mention for a minute is how you would define a fall. And like I mentioned earlier, we're going to focus today primarily on prevention and the community setting. But the reason falls, the definition counts, is because we've got to find a way to measure these things, and they're already not being reported. The CDC says that they think about half of all falls go unreported. That's a pretty significant number when it's driving the cost and suffering that we know about. So let's talk a little bit about why and how a fall is defined. Next slide, please, Sean. Thank you, sir. So if you look at anything about falls and balance anywhere in terms of research, you'll find this Dr. Chinetti everywhere. And he and his associates say that a fall in the non-hospitalized geriatric population is defined as an event which results in a person coming to rest unintentionally on the ground or lower level as a result of a major intrinsic event, such as a stroke or overwhelming hazard. Now, that's a mouthful. The reason it's that detailed is so that we can, kind of pay more attention to what is the causation of these falls, and from there we can learn more what to do about it. And environment really impacts the meaning of a fall. So for example, there are in an assisted living facility, you know, a fall is going to be defined as simply any kind of loss of balance or loss of control that results in going to the ground or lower level. The lower level wording is important because I see so many folks will say, oh, well, you know, mama didn't really fall. She just kind of sat back on the chair really hard. Well, I mean, maybe the next time the chair is not there, it's a fall is a fall, whether there's a harm from it or not. So you'll, you know, as you're looking at that, if you happen to be one who writes incident reports or is responsible for monitoring those falls, you know, it's good to keep in mind that just simply lowering one's level in an uncontrolled fashion is itself a fall and represents fall risk. So in an acute definition for inpatient, acute, and long-term care areas, to define a fall as unintentionally coming to rest on the ground floor or other lower level, but not as a result of syncope or overwhelming external force. So the intrinsic and extrinsic factors that put one at risk are coming up next. Next slide, Sean. You know, some of the definitions are expanded, and they include details like was the fall in from related to an intrinsic or extrinsic fall risk factor. An example of an intrinsic fall risk factor may be something like peripheral neuropathy, where your patient can no longer really feel where they are on the face of the earth with their feet. A stroke that impacts limb movement. You know, something like a fracture that's already there, an injury. Diabetes being out of control can not only increase the risk of neuropathy, but can also make a person dizzy. So there's a fall risk that's intrinsic or endogenous there. And like the acute care definition is even longer and more complex, but I'm not going to go down that pathway. It'd take a lot of time, but basically it too points out that the reasons for the fall in the environment and whether it's an intrinsic or extrinsic causation are important to understand, know what we can do about it. Next slide, please, Sean. Thank you, sir. So what is a fall? So you see, the reason this slide is in here just to show you kind of how complicated the whole fall and treatment situation can get. You know, a patient falls, we got to get the first of all, we may have to transport them to the hospital and give supportive care in that way, but we need to understand the nature, the location, and the environment in which the fall occurs. In healthcare, the way a fall is defined is also described as related to how the fall is to be reported and documented. Okay, Sean, next slide, please. So before I launch off into risk factors, is there anybody that could y'all share with me some of the risk factors that you've seen in the community that affects your patients?
And I'll interject here, CW, to say that many of the folks who've been here with us before are pretty talkative. And so generally when I ask a question like this, I'll give them a minute and then we'll be inundated. So Ms. Langford says medications. Janet Boozer says medications. Amy Jo Mans is taking 4 or more medications. She learned this with us recently. Ashley Talbert says carpet and rugs. Gail Thrasher says medications, balance problems, and sight problems. And Artidra Siggers says clutter. Betty Potts says shoes. Ashley Talbot says pets.
Those are all great examples, and they all hold true. Absolutely every one of them. So, you know, there's a lot of mention about medications and fall risk, and that's only gotten more attention over time because more research has shown that one of the best things we can do for elderly folks sometimes who are at risk for falls is to de-prescribe, to cut back on the number of medications that they take, and to look closely at why they take them and appropriate dosage adjustments. Any medication that can be taken off that, in short, now there's more detail to it, pretty much almost any medication we can take off that list actually is going to reduce fall risk.
Lisa Fountain says, and I think it's an interesting point, CW, she says people may fall because they have a hard time adjusting to changed ability levels?
Absolutely. And then there actually is some conversation about that could go on around that about overconfidence for one thing. And one of the things I say is pride cometh before the fall, literally. So people don't want to admit that they're having trouble adjusting. They, when this is happening, it's kind of a blow to their ego. They're used to being able to get up and do whatever they want to do whenever they want to do it. So, for example, one way that I found that information useful is, when I first got into working with balance and falls and patients in homes, I would want to talk to elderly folks about their risk of falls. We don't want you to fall. You could suffer a hip fracture, whatever. Well, that is sure to discourage them. We want to focus on independence because they're already afraid. They know it and they don't want to admit it. So we want to focus on the independence as an encouragement rather than some of them look at therapy and other interventions as sort of almost like punishment or taking something away from them. The pets is a really good example. I cannot tell you how many folks I have personally talked to that were in the kitchen, at the stove or the sink, and turn around and take a step away and boom, there's Fido. And they fall over Fido. And of course, we love Fido. Fido is not going anywhere. You can have that fight all you want, but mom or dad are not going to get Fido up if they can avoid it. Related to the medications, postural hypotension is a biggie for those on cardiac meds. And just simple basic nursing instructions about staying hydrated, putting your legs over the foot of the bed and dangling and all those old school nursing things still really work, are still very effective in your education to your patients. But, most of our patients are octogenarians, so to speak, in our day. And so they will require probably some reinforcement, some kind, gentle reinforcement about those basic nursing measures. Benzodiazepines or sedative hypnotics, that actually, sort of touches on another reason that I think people fall, and that is cognition. When you're on benzodiazepines and other sedative hypnotics, your judgment is impaired, your memory may not be what it normally is. And so it's like if you can imagine, an iatrogenic dementia temporarily from taking those medications. The same holds true for pain medications, not to mention many of those medications will also cause postural hypotension. One of the risk factors that didn't come up in our questioning a minute ago is muscular strength and range of motion impairment, particularly in the hip and upper legs. There's a lot of evidence to say that one area of weakness is a strong contributing factor to falls in the elderly. Next slide, please. So let's talk about I'm going to sort of launch down a pathway talking a little bit about intrinsic and extrinsic risk factors and begin to touch on modifiable risk factors. So some risk factors that we would consider intrinsic are the comorbidities: diabetes, diabetic foot ulcer, a stroke, syncope, Alzheimer's, Parkinson's is a big one. A vitamin D deficient. Let's see, we're learning more and more about that, and more and more elderly folks are on vitamin D thanks to good doctors. And if there's any kind of renal impairment, that's going to increase, may have a synergistic effect on whatever medications are taken. I'd also say if there's any liver function involvement, that needs to be taken into consideration for fall risk when given multiple medications, particularly in the elderly and particularly those who have multiple comorbidities wherein the kidneys and the liver are challenged to begin with. There is the fear of falling. I've already mentioned it, and there's a little thing here, fallophobia, which I think is kind of cute. And there's another word for it that I'm having a blank, basophobia or something to that effect. That is really focuses on the concept of fear of falling. Fear of falling in and of itself is a risk factor. It's also a risk factor that is semi-modifiable. We can take actions to help reduce the fear of falling and hopefully instill a little confidence, and while keeping in the forefront of the resident and patient's mind the safety factors they need to keep on their mind to keep from falling to begin with. So fear of falling, the reason it becomes its own separate fear risk factor is because folks who have fear of falling, they tend to shorten their stride, lower their body, lower their hips, so to speak, And when you shorten your stride, or a patient shortens their stride over time, and that becomes a habit, also when it comes to a certain kind of weakness, there's quite a few studies out there that indicate that stride length may be indicative of fall risk. Let's think about our Parkinson's patient with a shortened stride length. That one thing, just the shortened stride length, puts them at risk. So you can have patients who are doing that, quote, voluntarily and increasing their risk by walking with short steps and all hunched over and keeping their bottom low to the ground. And I see it all the time. Then that leads to things like isolation, where that patient is afraid to get out. They're just going to stay in their house so they don't fall. And the fact that 2/3 of the falls that occur in the United States occur in the home doesn't seem to matter much to most of them. They're not leaving the house. We've got a person who has trouble with their ADLs, putting their pants on and off. It seems like a minor thing, but if you've got a person that has trouble getting clothes on and off, one good fall prevention strategy would be to have occupational therapy look at that patient. Something like a reacher or discussing pants that are too long or ill-fitting could in and of itself save some falls. Somebody mentioned earlier, adapting to a changing environment. That is absolutely true. One of the things when I'm helping families and facilities to get a new resident into a community, I almost always mention, particularly if they're going to assisted living or the dementia unit, the risk of falls going up during that first couple weeks that they're in that new environment. The furniture is in a different place. The lighting is different than what they're used to. They may feel kind of anxious, and being anxious can impair judgment. They may have a cognitive issue, which is part of what got them there to begin with. So it's really a good idea when you change an individual's environment to go ahead and prepare for that and to educate your patients and family about that risk and see if they'll be willing to take action with something like receiving physical therapy. Along those lines, I want to put in another plug for assisted living here, because if you got patients that are falling at home, okay, so there's so many ways that could go, right? I fall and I can't get up. I worked with a resident recently who had been on the ground for 5 days in their kitchen, and had some injuries as a result, not of the fall, but of the fact that she couldn't get up and couldn't reach the phone. When you see that happen, we're talking about compression injuries, necrosis, nerve injuries, some pretty bad stuff that could even result in death. So emphasizing that risk of falling at home and doing everything we can to keep the resident, the patient's focus on that, the family's focus, and in our case, often the community's focus on that when they come in is very important. A recent hospitalization, that one kind of is self-explanatory because most folks are weakened and confused, just having to go to the hospital. Just when I feel weak and confused when I go in the hospital just to work. Footwear, somebody mentioned footwear. That's a great one. Footwear needs to be closed-toed, and there's some conversations we have, particularly with some ladies, about these shoes and the house shoes, because like the little rugs, they don't want to give them up. Keeps their feet warm, they're comfortable, they're easy to get in and out. And what I'm thinking about mostly, the number one fall thread in the way of footwear to me is those open back slide in sandals that the ladies wear around the house. Most of them have a slippery sole, and your foot can pop right out of that, and you can fall just from your foot coming out of it. So I really talk to patients about, if they have trouble with tying their shoes, this kind of thing, maybe we get some Velcro shoes, but we need something that's going to stay there. And someone just.
Camilla Dean says a lot of hospitals reinforce patients not getting up out of the bed alone. This for dementia patients could also contribute to them being high fall risk, which I think is an interesting point. And Beverly was thinking what I was thinking, flip-flops.
Oh my goodness. Well, the flip-flops are they don't need to be in anybody's closet, frankly, if you got any kind of fall risk. But if you have a family member or a patient you're working with or a resident in assisted living and they're wearing flip-flops, it is time to have a conversation because those need to go. There's no support there. A foot can slip out of those so easy that you don't even really have to be doing much to fall with those on. I appreciate the comments about medications earlier too, because that is absolutely, you guys are totally on track. Psychotropic medications are mentioned here also as a big risk factor because they too can contribute to postural hypotension and may have some effect on cognition. Next slide, please. So a prior history of falls and the fear of falling. So we got four primary systems of balance, visual, vestibular, proprioception, which is basically your ability to feel where you are on the face of the earth with your muscles and nerves, and vision, proprioception, and inner ear, and I'm forgetting, but let's just focus on those. Musculoskeletal. Vision is an easy thing to address, and we probably should be addressing it more often than I think we do with our patients. I can't tell you how many folks I've talked to in the home, elderly people, and particularly those who live alone or with another elderly person, who you walk in to talk to them and their glasses are on sideways and they look like they got milk on them. They're so dirty. And then we're wondering why they can't figure out where they're at. So, frequent doctor's visits to have the eye exams are important, especially for diabetics. And just something as simple as seeing a optometrist or an optician to get your glasses adjusted and maybe get them really cleaned up good is not a bad idea if you've got a loved one who wears glasses in that circumstance. Inner ear that's where we get things like BPPV, some vertigo, which is in itself an intrinsic factor that we may or may not be able to control or have any impact on. You may have seen patients that has vertigo so badly that you can see their eyes going back and forth when they're just sitting down. So for those poor patients, that problem cannot be alleviated in many circumstances. So treatment becomes more about habituation than actually fixing the problem. Musculoskeletal weakness, this is another opportunity for us to have a positive impact because through therapy, going to activities, participating in community events, those all have a very positive effect on strength and balance. Loss of sensation, peripheral neuropathy, I mentioned that in passing earlier, but this is a huge fall risk. If you can't feel your place on the earth, you don't know where your foot's going next. Between that and sort of what I would call occult foot injuries, where the patient is not even aware that they have a foot injury, can also put the patient at risk for falls. I had one gentleman who was falling, and when the therapist went out to do the evaluation, did the Weinstein testing, they found he was a golfer. He still managed to get around the golf course, perhaps not wisely so, but they found he had a big hole in his foot. When we sent to the doctor, he had been golfing that weekend before. He had and he had fallen again. He had a golf tee inside of his foot. So surely a golf tee inside your foot would affect your balance, but the guy didn't even know he had it. So you got to be vigilant when you're working with these patients that are at fall risk to remember good foot care and good foot inspections, including going to advising your patient to go to a podiatrist or to see the doctor if there's any question about the condition of their feet. One thing I will note on the point of vertigo and vestibular dizziness is that there are now some treatment modalities out there having to do with vestibular rehabilitation and some very specific maneuvers that physical therapists and doctors can do that will sometimes put the little otoconia, the little rocks in your ears, in a patient's ears, back into their place. It doesn't work all the time, but the few times I have seen it work, it's been just basically miraculous because you'll have a patient who one day can hardly walk across the house, a few treatments, when it's effective, and they may be able to go even without a walker. It's rare, but it happens. It's exciting news that it's been developed. Okay, and labyrinthitis, a lot of people don't think about labyrinthitis. You can get a labyrinthitis just from having had a cold or the flu. Anything that will kind of inflame those passageways can cause labyrinthitis. And having had labyrinthitis, it is a frightening event, and you are definitely at risk for falls because it so disorients a person. So if you've had a cold or have a loved one's got a cold or a flu or something like that recently, and they start developing new dizziness, it's time to go to the doctor. Next slide, please, Sean. Okay, so what are some ideas about how we can reduce the risk for falls? Something that I haven't mentioned.
Are we thinking environmental here or something else?
Anything we can impact, environmental, intrinsic, extrinsic, anything we can impact is what I'm looking for. Something that's actionable.
Well, Betty Potts said it above, but I think it applies here, certainly for people that I've worked with, is furniture surfing. In some respects, like in a small assisted living room, that's actually a benefit for someone who has mobility issues and maybe dementia. The fact that we've made their environment smaller, they can actually furniture surf to the bathroom, which is not ideal, but it's better than having nothing.
That is true. However, I appreciate you mentioning that, Sean. When I see that, that's a symptom to me. That is something that means we need to address environmental factors and balance issues to me. When I see a patient furniture surfing or clinging to their loved one's elbow and putting their hand out to the arm when they're walking down the doctor's office hallway. And you'd be surprised, a lot of doctors don't really register or think about that. And I've talked to several doctors over the years about, Miss Jones came in and she was clinging to her daughter's elbow for dear life and put her hand on the wall every other step and wobbling. Can we take action about that? Can we get some physical therapy to see that patient? Folks just don't think about it. And like you say, it can be a good thing, but it can also be a false sense of security for those residents. I worked with one in particular, a local facility some years back, who she insisted that her furniture had to be arranged the way it was, and that she had to use her walker the way she had to use her walker. And there was no room for change for that. And she would even take her walker beyond the door to her apartment. Well, needless to say, this lady fell several times and had to go to an alternate environment over time.
So
Yes.
Teresa Carpenter says grab bars. Artidra Sigger says exercise. Beverly Jackson says shoes fitting well. Camilla Dean says make sure items that are important are in reach. Priscilla Hinton says declutter. And Janet Boozer says walker, cane. And let's see, Gail Thrasher says to prevent, ask people in middle age to walk or do other exercise regularly. Well, that's certainly true. I need to be doing that.
That's a good one.
And Beverly Jackson says remove trip factors like rugs, mats, good lighting.
Absolutely. That last suggestion is huge. Having been in a lot of homes and home health care, I cannot tell you, and I'm sure you people out there with me right now have experienced this, where you walk into that home for that fall risk patient and there is a cord going across the kitchen and 3 rugs that stand up on the corners across the floor. And especially these little ladies don't want to give it up. Their feet are cold. They do not want to give those rugs up. They don't want to have to move their little heater around. But you have to continue to try to educate them about the value of that. And I know that they're resistant, but you got to try. I have an example of a patient that I had over probably a year or so. I was the case manager for that case at home. She had diabetes, terrible diabetes, and got down to one leg. Imagine that. And she was cold natured. I would go in her house in August and she would be wrapped up in a blanket with a space heater right at her feet and the rug that she had already fallen over touching the space heater. And I tried to talk to her and her family. And finally, there was some kind of like, we're going to have to discharge you. We can't work with you like this. So then they disappeared. The cords and the rugs disappeared until one day I showed up unexpected at an alternative time. And when the lady asked me to come in, the first thing I saw was the cord, the heaters, and the rug. So yes, it's a daunting task to get folks to pay attention to that, but don't give up. It's important. Next slide, please. So you're right on. So modifiable risk factors, you guys are already on it. One thing that I didn't hear mentioned is uneven or low lighting. You go in a lot of houses where there's falls happening. You'll have a lamp here and a lamp there, and maybe mom or dad by themselves, they can't replace the lights in the overhead fixture, or maybe they're in an environment that a small apartment or something where they don't even have overhead fixtures. Just the change in lighting is a big risk for elderly folks. As we become increasingly birthday blessed, our eyes no longer accommodate their tendency to react to light, and to adjust to a new level of light in an area is difficult. Shadows are fall risk for folks if they have really dark spots in their home. You know, that's where they're likely to lose their footing or lose their orientation to where they're at. Uneven walking surfaces and stairs. Now, when we all love to put every one of our patients in a nice flat apartment with no stairs going in and out, that would be lovely. Unfortunately, we don't have that option. And when I see uneven surfaces and stairs involved, if that patient is not already getting physical therapy, it's probably time to ask for that order. Too many unnecessary or inappropriate medications. We've already discussed that, but you know, that's another reason to make sure that your patient, your resident, your loved one sees their doctor regularly to review those medications, particularly if they have recently been hospitalized and or been to a skilled nursing facility. You know, I think one thing I learned when I started taking care of folks at home is that you know, by the time a patient goes through hospitalization and a skilled nursing facility and they get home, they got 3 bags of medicines, 2 sets of orders, and none of them match. They've seen several the specialists. The specialists may not be talking to each other effectively. And so you have a medication list that's 15 medicines long, 5 of which could immediately be deleted for duplication. So that's a very important thing to look at and make sure patient sees that doctor, carries their medication list with them, and takes their medication in their giant bag in their purse with them so that the doctor can see that. Pets, need we say more? Yes, Gail Thrasher. Don't wear anything slippery like socks without shoes or slippers. Very good. And that's how we get to the little socks with the rubber on the bottom of them. They're uncomfortable to me, but they do help reduce falls in the acute care environment. That's a very good point. Next slide, please, Sean. Okay, so here's some modifiable risk factors. So alcohol. There's some evidence to say there's some health value in limited alcohol intake, but there's a lot of evidence to say that if you drink a bunch, you will fall down and go boom. So that's seems like a simple thing, but folks don't always associate those two things together. And I tell you an aside about that, I have a facility that I've been in a lot, and one of the community parties that they had there a few years back, one lady ripped off 2 bottles of wine in her rollator to take back to her room with her. So, you know, needless to say, there was a little extra vigilance about her ambulation for the next day or two. Poor visual acuity, absolutely. If you're a loved one or a resident patient has poor visual acuity, let's get them to the doctor, get their eyes examined. You know, not only might the visual acuity itself be a risk factor, but there may be things the doctor can learn from an eye exam about their overall condition that may help with fall risk too. For example, if they're developing macular degeneration, or they have glaucoma, or they have blood pressure related changes in the back of their eye, then that can be an indicator of some changes we may need to make to decrease fall risk. Hearing loss in and of itself has been found to be a risk for falls. And I think, you know, I've kind of pondered a lot about that. I think probably it's due to disorientation. That's my own theory. But I think when folks can't hear what's going around them, it's a little disorienting, and they may miss cues like don't step on that cord or something to that effect just because they don't hear it. Musculoskeletal weakness, everybody needs to exercise. Everybody needs to stay active. And that's one thing I love about putting patients in the assisted living facilities, is because they have everyone that we work with has an exercise program and an activity program that does more than just help keep the muscles stronger and flexible, but it helps by reducing isolation. And the activity tends to improve mood, which those things together can become their fall risk. If you have a patient who kind of hunkers in their room and doesn't go anywhere, well, they're losing their balance by the day. Bad footwear, we've talked about. Loose clothing, I have seen this one quite a few times, particularly in ladies at night. And I put the loose clothing and the nocturia and urinary urgency together because I've had more than one patient that had to get up in the middle of the night to go to the bathroom and had on long, flowing, beautiful pajamas or some kind of a long gown, that they got it caught in their feet and fell over that. So that's something to watch for. I think a lot of people don't think about pants being too long. Nocturia and urinary urgency, there are some measures we can take for that. I won't go too deeply into it, but certainly it might be time to consult the urologist. I've had one urologist that for some time was sending me a lot of patients who have falls simply from getting up in the middle of the night to go to the bathroom. And it goes back to what one of the viewers said earlier about having things close by. You want to have that, make sure your patient knows, and it requires repetition over and over again with many residents and patients. Make sure that their walker is right there, their cane is right there, and that they actually use it when they go to get out of bed. Make sure they have their phone at hand. If they need water or whatever to drink, anything you can have by that bedside, including, if necessary, a bedside commode and or another environmental modification to move the bed closer to the bathroom. Those are all good things to consider. Next slide, please, Sean. Yep. Okay. Throw that old rug in the trash. So we don't really need to beat that dead horse, but that's an obvious one. And prepare for a battle when you're ready to do it. Remove and dispose of any unnecessary paperwork. Anybody ever notice how slippery paper is? You have patients, residents in their home that will use their floor as part of their filing system. Get up to go to the bathroom and slip on a piece of paper. It happens. Toss magazines, mail, or boxes that may clutter in walking paths. You want to make sure there's plenty of room wherever those typical walking paths go, preferably with a walker and without furniture surfing. The problem with the furniture surfing is one day the furniture is not there when that resident or patient puts their hand out. So they've got this false sense of confidence that we could kind of reduce the risk by making sure that they understand the importance of using their walker or their assistive device. Let's see. We talked about lighting. Talked about the medications. One thing that you might want to do is ask. The pharmacists have gotten better about it mostly because it's computerized. But you might want to ask your doctor, or your loved one's doctor, or your resident patient's doctor, if they if there's anything that they think, if they would even just review the medications and try to do a reconciliation of them periodically, because things get prescribed and the PCP who rely on may be the last person to know about it when he's treating that patient. Okay, next slide, Sean. So the modifiable risk factors are where the action is. So the first thing I put on here is exercise, exercise, exercise. If you can do any one thing for yourself or your loved one to reduce your fall risk, it's staying active and exercising. It works your vestibular system, your musculoskeletal system, your respiratory and cardiac system. It gets you out of the room or your loved one out of the room and reduces fall risk for all of those reasons. Even if you have a loved one or a patient that is not in a facility where there are activities, helping to encourage them to get out to community activities and doing things like providing schedules for local senior events and this kind of thing may be a big service to those patients. Dancing and Tai Chi are highly recommended for fall risk reduction. They both work on the four primary systems of balance. Next slide, please, Sean. Okay, have you ever suffered a fall to the point of injury, and how long was your recovery?
And by the way, the CEU password is our name, CarePatrol, which is a capital C and a capital P, no space. CarePatrol is today's password. And I think the question is, well, I know the question is, if you're comfortable sharing it with us, if you've ever suffered a fall to the point of injury and are comfortable talking about it, we'd love to hear your story and how you recovered. Alice Delois Alexander says dryer sheets are slippery, and they are very slippery. They're very slippery. I've slipped on them before. Can we please get the link again to the survey? Yes, ma'am. I'll put it in the chat room and we'll move on in the slides.
Thanks, Sean. So, I can't say enough about physical therapy. And while I mentioned that too, in line with what I was talking about earlier with vestibular rehabilitation and hearing loss of impacting fall risk, it's not a bad idea at all to get a referral to an audiologist and ear, nose, and throat doctor if there's any question about dizziness and hearing. Sometimes something as simple as adding hearing aids on can really reduce a person's fall risk. As well as some of the audiologists can also do the vestibular rehabilitation maneuvers that I mentioned earlier, and sometimes get a pretty pretty amazing improvement. Next slide.
I'm sorry.
Okay, I think we've hit pretty much all that. Next slide, Sean. Yes, so here we want to talk about the nocturia and frequency again, especially for the ladies. I don't mean to single them out, but it looks like you ladies do have a little extra burden when it comes to nocturia and frequency. So just limit fluid for your patient, yourself, your loved one. Limit fluid intake for at least 2 hours before bedtime. Certainly, if you have a resident or a patient who is taking their Lasix at night, this is indeed a fall risk, and it's good to educate those patients to take them early in the morning when possible. I've seen quite a few falls just from that one thing, the patient not understanding it. So you want to get them to take their diuretics as early as possible in the morning. Make sure that the walker is within reach. I see patients walk away from their walker all the time. Check the lighting between the bed and the commode. That's another big fall risk in the middle of the night. Next slide, please, Sean. There you go. I want to mention one more thing before we leave. There was a mention in that prior slide about pull-ups. And I know sometimes it's a hard thing on the ego and pride to have to start making adjustments over your urinary pattern. But what I've tried to explain to some elderly patients before is it's just not worth the risk. A little embarrassment for a moment, or the inconvenience and time and cost to put on a pull-up may save somebody's life, literally. So it's not a bad idea to talk to them about that. Next slide.
Thank you, CW. I think you've done an excellent job. I was really more nervous than you were about this, and that is, I must say, a high bar you've set. But I was more nervous, but you've done an excellent job. Clearly, it makes so much sense for us to involve and invite clinicians to speak on topics, because there's just an added layer of nuance and experience that someone like you brings that I could not. And I certainly appreciate you stepping up and offering to do this. And again, you've done an excellent job. I'll read our evaluation link one more time. Anybody that's not looking at the screen, the link is https://www.surveymonkey.com/r/all uppercase letters, M as in Mary, R, S as in Sam, B as in boy, Y, W, M as in Mary. That's our evaluation link. The password is CarePatrol. Our name, CarePatrol, no space between care and patrol, one word. CarePatrol, capital C, capital P. Everything else is lowercase. We thank y'all, as always, for being here with us today. Thank you, Katrina, CW. She says, thank you, wonderful and useful. Deborah Dickinson says, great, very practical. Amy Jo Mann says, thank you. Ashley Tolbert says, thank you. And we're so pleased to have you here with us, CW, not only to deliver today's content, but to work for CarePatrol and bring your knowledge and expertise and character to bear for our clients has been a very wonderful injection to us. Artidra Sigger says, great job. Camilla Gaines, thank you. Wendy May, thank you for all the information. Violet Phillips, thank you. And I have to say, Violet Phillips has been with us a while, even after I did a presentation about Medicare Advantage plans that wasn't necessarily complimentary, and yet she works in that milieu. So I'm glad to know that she and others find this valuable and worth their time, and hope you all continue to tune in to Care Concierge with CarePatrol on Mondays and Fridays. On this Friday, Dr. Duxbury will discuss Medicare 101. Do yourself a treat if you haven't heard this talk, and tune in Friday at noon. Go to our website, carepatrol.com. I see I made you laugh, Ms. Phillips. Go to our website, carepatrol.com, and you can register, or I think you probably have an email from me as well. with the link. So thank you all for being here. Thank you, CW. Is there anything else you'd like to add or say?
I just appreciate everybody participating with us today. And I look forward to seeing you all out there in the community. And any kind of suggestion you have for other classes that may be beneficial for you, me and Sean and Jennifer, we're all listening up for your suggestions. Thank you so much for joining today.
Thank you, CW. I'm about to end the recording for